And again, I'm Angie Grover with Metopio, and I have the pleasure of starting this webinar, and we are excited. I know that many of you, if not all of you on the call, are addressing maternal health disparities every day, and for good reason. The Centers for Disease Control and Prevention maternal mortality statistics show that non-Hispanic Black women have a rate that is more than double the rate of mortality for the entire population, and women in rural areas have a maternal mortality rate that is double that of women in urban areas. So in today's webinar, you'll get a preview of soon-to-be-released research from Heartland Forward, a data snapshot of maternal health variables for communities, and we'll wrap up with a discussion of how this information can really empower action. So today, I'm really pleased to introduce our panel. I have three members of the Heartland Forward team. Dave Shideler serves as the Chief Research Officer for Heartland Forward's research team, where their original research efforts focus on four key pillars: innovation and entrepreneurship, human capital, health and wellness, and regional competitiveness. And Dave joined Heartland Forward after more than a decade. Dave, I didn't know you were a professor and a community economic development special. He has a PhD in agricultural, environmental, and development economics, a master's in economics from The Ohio State University, and an MS in agricultural economics from Pennsylvania State. Oh, and not to mention a BS in community and rural development from Clemson. So definitely a guy who knows what he's talking about. We have Maria Rodriguez-Alcala. She is the Director of Health and Wellness for Heartland Forward, and she really likes to apply a holistic approach to her work. She's been a researcher, an instructor, field faculty for the University of Missouri, and has also worked in Sao Paulo, Brazil for ICONE, an applied economics-based think tank, and Washington State University. Her multidisciplinary background, combining her international, statewide, and more recently local community level experiences, really allows Maria to bring unique tools to the table to help change the approach on how to improve health, particularly in the Midwest. She has a BS in Applied Economics from Texas A&M University, an MS in Applied Economics from the University of Missouri, and a PhD in Sustainable Development from the University of Missouri. And finally, Will Trolinger joins us today. He started at Heartland Forward as an intern and played an important role in this research we're going to discuss. Will graduated from the College of STEM at the University of Arkansas, Fort Smith, with a degree in computer science and has a particular interest in AI. So with their combined experience in health and economics, I know this is going to be a really interesting and great conversation. So let's get started. I just, to get everyone started, I'm familiar with Heartland Forward, why this topic and why now? Dave's looking for his, I've got to come off mute button.
Yeah, sorry. So just quickly, at Heartland Forward, our mission is to be a resource to state and local governments to advance economic success. One way that we do this is through the belief that we have to have a healthy workforce that is able to participate in formal and informal ways in the economy. So the work we're going to be talking about today, focused on maternal health, is focused on a specific segment of the workforce, i.e. women, participation in the workforce, again, both through formal and informal means. But really is a piece of the story that is in a broader portfolio that we have looking at women's barriers to workforce participation. So that broader portfolio is really about how can we ensure that women are empowered to work and to support their families in the way that their families need to be supported.
And top line, this research, what were some of the key takeaways? And we'll dig into how you got to, how you dug into this, what your hypothesis was, what you put together in terms of getting to those key takeaways. But for our audience who might not know Heartland Forward very well and are getting this first look at this research, can you guys tell us a little bit about the key takeaways from the research?
So yeah, I'll go ahead and go with that. Some of the main things that we really looked at, and the main things that came to us, was the adverse birth outcomes and the rate of those in rural areas, the accessibility of different maternal health services, things like that. Some of the social determinants of health,
So
but,
I
but
like,
the main things. Go ahead.
no, sorry, I thought you were done, Will.
Yes.
I like the qualitative portion, and I would say that the key takeaway from that perspective is that we are kind of stuck in one model on how to provide maternal health care in the US, and we need to change that mindset. And changing mindsets is not always easy. And not just for the patients, but also for the providers themselves. I mean, right now we're stuck in this idea that only OBGYNs can provide maternal health care. Whereas in many other countries, midwives are the ones that provide a majority of the maternal health care, and OBGYNs provide primarily the ones for the higher risks. So that's just a snapshot of what kind of we got from the interviews on looking at this in a different way and how we can do things differently.
And I would just add too, given that, or I hope many in the audience are data users, I think we were surprised and grateful for the qualitative input that we received, because when we started digging into the publicly available data, it's not just publicly available at the state level because they want to restrict access to it. It's in many states, there's actually not enough observations to really go at the sub-state level. And so, you know, in terms of kind of a surprising finding or a challenge that we faced in putting some of this information together was really not having the underlying data that's needed to make really good use of government resources, especially at that sub-state level.
Yeah, I think Maria and I talked a little bit about this, that, you know, if the data is collected, they may not share it, or they may need to suppress it to protect privacy, or they just simply, you know, once you get into data investigation, sometimes you find there's no one question, one answer. It's one question, lots of research, lots of factors that go into that. So I'd be really curious about how you guys thought about access to care as you did the report.
Yeah, so for us to look at terms of access to care, we had to first define how we want to measure accessibility, because there's a lot of ways to measure accessibility. And we came across an algorithm called RAM that takes in a few inputs that would be the population, the number of providers, and then for us, we use the time and distance and duration to get to these facilities. And the algorithm itself calculates a access score, I guess you could call it. And so that's really how we observed it, but making sure that we got kind of the population in there too, because that's extremely important. If some areas have a ton of places, a bunch of facilities, but there's a lot more people sharing them, then obviously the access is still not going to be that high.
Yeah, I think one of the uniquenesses of our approach in terms of access is really providing this balance between supply and demand. So if you haven't figured out by now, I'm an economist by training, and you know, and so it's really about not just, you know, number of providers that might be available in a county or a county and its surrounding counties, neighboring counties, but it's really also we try to take into account kind of what is that the demand based on population estimates and population density.
And, you know, we talked about, in addition to that, we also talked a little bit about who is providing these services and are they available? Because I know I'm going to share a map where we show hospitals, but we know, especially the pressures around hospitals, and a lot of rural hospitals have stopped providing care. So, you know, Maria, in combination with the social determinants and trying to identify where those services were, could you talk a little bit more about what you evaluated to really think about a woman's entire childbirth journey? I mean, we know I'm blessed to have 2 boys, and I know it started when I started thinking about having kids, and, you know, it's going to go on for the rest of my life, really, pretty much. But
Yeah, sure. I want to attack first and start with, okay, so when we're talking about supply and demand, we're talking about, okay, supply is the providers that provide the service. Demand is the women that are looking for perinatal care, right? But there's another component there that we measured also. I didn't, but Will and, and the research team did. The transportation, right? So if you today look at maps across the US in the States, you will see that Medicaid transportation providers that are paid by Medicaid are pretty much everywhere in most states. But when you talk to people through the qualitative interviews, that's not what's happening in terms of being an effective use of transportation. So we need to be able to find a better ways on how women can get to their appointments fast and not lose a whole day of work, not having to look for childcare, and then having another economic loss in their lives for that day, or maybe sometimes even more so because they have to go more regularly if they have more appointments to get to. So just scheduling those transportation services is a hassle for most women. It's not easy to navigate. It may even cost them out of pocket sometimes, and they're confused. Sometimes those transportations get there late. And again, they may be missing a whole day of work and need to figure out childcare as well. But then when you start thinking about other social determinants of health, lots of the issues are also women not being able to understand the system and not feeling comfortable to be a good advocates for themselves as patients. So there's this kind of cultural aspect of it. There's also, that's where doulas play a big role because they teach women, they help them to be better advocates in the medical system. And this is not to say that the medical system is doing anything harmful on purpose, but the way that we have come about addressing maternal health care, unfortunately, has made it very medicalized. And this traditionally has not been a medicalized way of doing things. And so women are feeling like they're not being treated as a person. And that's where the doula and also the midwife can play a better role. And OBGYNs also want to do things differently. I want to point that out because I don't want to be putting any blame on anybody here, because everybody that we talk to, and we talk to doulas, midwives, OBGYNs, all these people that are serving high-risk women population, and they all want to help. They all want to make a change. But I think what's lacking there is this coordination among providers and also even this advocacy for this woman to be able to advocate for themselves also. So that, which impacts their health literacy as well.
And I think those are all the things that we, those of us who work with women in this situation, you understand that the scheduling piece on top of that means you have to take time off work. That means that childcare is a real consideration. So when we talk about the social determinants of health in a situation of maternal health care, this may not be your first baby. There's just a lot of juggling that somebody has to do to cover all the bases. And I wonder, Dave, I don't know if this is for you or Will, but as you think about that economic impact, I know you looked at how, adverse outcomes also impact like lifelong learning and, earning and all of those other things. Could you talk to us a little bit about that as well?
Yeah, I'll intro it and then Will, you can take over. But yeah, basically, we looked at the economic impact on a couple of levels. And so the broadest level being kind of a loss of productivity associated with a lack of maternal health care, as well as the infant implications of that. And so that takes two forms. So one is you have this loss of a worker because of premature death, whether that's the mother or the infant, in terms of the kind of the next generation workforce. But then you also have, in the cases where a live birth happens, mom and child both survive, but maybe there's effects associated with the birth or the pregnancy that impact the child ongoing. You again have these long-term effects, where you have mom's got to take time off to make sure that the infant or the child gets the care that's needed, whether it's developmental or physiological or biological, care. And so we look at those different costs. So again, first it's that loss of productivity. Then we looked at medical costs associated, building on some work by some other researchers that actually had access to medical claims data. And then we look at some of the indirect costs, as we've talked about already, in terms of transportation costs and the opportunity costs to the mothers of having to go and seek care. One of the things that we didn't realize, but I think we were all surprised by, is 1 in 3 women have to travel out of county or choose to travel out of county to receive prenatal care and deliver their children. And so when you stop and think about the amount of time it takes to drive to the next county over to get care, or 2 counties over, those costs really become significant. So, Will, I don't know if you want to share some illustrations.
So, big picture wise, you covered it. I can dive a little bit deeper if there's any questions. But like he was saying, is we were looking at the impact of a mother having to travel to go take her prenatal visits or to deliver her child, and that takes time away from her day and money away from the economy.
Yeah, I also want to stress out the role of preventive care, how important that is. And with that, I include gynecology services, because when you think about Medicaid, a lot of these rural providers, if they take patients with Medicaid, they will only do the OB portion. They will not do the gynecology. That means you're taking out contraceptive. In Arkansas, we heard from several providers that over 50% of pregnancies are unplanned. And many of those are young women from the age of 18 to 20 something. These are women that maybe they weren't planning on having a baby, and then that changes their future careers, whatever they were thinking of, that maybe if they would have had access to gynecology services, they probably would have access to better contraception and would have been educated by their gynecologist on time. But at the same time, even sexual education when they're young enough to understand, and so though we can prevent some of that of that huge portion of unplanned pregnancies that are happening, and particularly with young women that are just like maybe they have a lot of hope in their life, and then suddenly they love their babies, but their future career prospects are completely dismantled at the time they get pregnant. And the other thing is the rate at which that right after they had the baby they get pregnant again also is very high. And again, that has to do with contraception, and we're not doing a good job. And by that, I'm completely excluding the topic of abortion here. If we just focus on other contraception or other forms, that is what we need to be doing for prevention. That is the focus. We need to respect that many communities are not in favor of abortion also. So what options can we give these communities? Because a lot of the people I talk, that is what they're saying. It's like they want other options and they're not in favor of that. And so we need to respect that.
Yeah, when you think about what you all have teed up in terms of, again, the social determinants, Will and Dave were talking about transportation in terms of how far you need to go. That assumes that you have a working car, or you have money to be on public transportation, and or you have the ability to have childcare so you can go for your checkups. And so, I mean, this is all compounding the challenges that somebody might face if they don't have the resources or the access that they need in order to have a healthy birth. So I just want to, anything we haven't touched on that your research really brought to light as you're thinking about how you are going to share this with communities or others. I'm going to show a quick snapshot of what some of these variables look like on Metopio and how we put them together. Just real quick, any other comments from you all before we look at the data snapshot? All right, so Metopio provides thousands of topics so that you can do a really fast analysis, whether it may be on maternal health or something else. And so I just wanted to show you here real quickly what that looks like and touch on some of the things that Dave and Maria and Will had mentioned. So I chose Arkansas, that's where Heartland Forward's located, but chose Arkansas. And here we have a quick snapshot of 32 different topics. Again, going to that question of what do you need access to and is there the data available? And what we're looking here is at Pulaski County in Arkansas, which is one of the more populous counties, against Cross County, which is about 18,000 people. And then Metopio is able to curate, and we do this for every state, a rural benchmark. And we think that's super important because disparities look different from the urban setting to the rural setting, and being able to look at what disparity looks like in your community, whether it may be a social determinant of health or a health outcome, is pretty important. And so as we look here, we can look across all of these different benchmarks to see the differences between median household income. We selected travel time to work over 1 hour. Again, if you think about commuting to have your appointments and your job is an hour away, and then maybe you have to go another county away to get your services, come back to work, pick up your kids, whatever it might be, that travel time really eats into the free time you have to care for yourself and your family. And then we have some modes of transportation. I thought this was particularly interesting. I saw a comment in the chat about reimbursement, and we've talked a lot outside of maternal health and on other topics about the need to connect people to access, and part of that is a transportation challenge. And if you live in a more urban setting, you might have public transportation, Lyft, Uber, and there are other transportation solutions actually out there where people are pairing the need. But I thought it was really interesting here in Cross County, which is more rural, that there was no vehicle available. It was quite high, even with the margin of error. And so we're looking at a place that might not have a public health or a public transportation infrastructure, and there's a part of the population that doesn't have access to vehicles. So that's challenging. And then when we look at demographics, so we're combining what does your community look like with some of the demographics. And here's where I want to point out, as we started talking originally, about the data available. And so Metopio curates publicly available data and allows our partners to put their proprietary data on the platform to look at all of it in one place. However, not all data sets are created equal. I wish they were. And I wish I had answers, data sets for some of the questions I want to ask. But you'll see wherever there's a dash, that means that the data is not available. So even the average age of mothers, everything is cited in our platform. So I'm going to go quick and say this is from the National Vital Statistics System that the CDC puts out. And so we can see that that data is available for Pulaski County, but not for Cross County or for our rural benchmark calculation. And we can look through these and see we have single mother households, the birth rate, the teen birth rate. Everything here is pretty much a survey. And so you will see on our platform, we always provide you with the margin of error. That's so critically important in your analysis. But also, you know, if you want to get down to a very granular level, that margin is going to get bigger and bigger. So you can aggregate up. We go all the way down to the census tract, so you can look at that. But you just need to take that into consideration as you're looking at these different topics. And then I also wanted to touch on, we talked about, you know, Medicaid coverage. And one of the things that we've done with some of our clients is look at providers that accept Medicaid. So when you look at all the providers we have, kind of the provider cliff we're looking at, and then the reduced number of folks who accept Medicaid based on the reimbursement in your state. Maria mentioned OBGYNs. So we have them curated per capita, as well as nurse practitioners and doulas. So you can look at what that accessibility looks like. And if you're in Cross County, you know, you're going to have to go somewhere else for the most part. And then we look at the health outcomes. So this is where I just want to point out, again, either the data is not released or it's suppressed to protect privacy. So here we can look at Arkansas and Pulaski County for a lot of these, but these are indicators, you know, of maternal health outcomes. So infant mortality, low birth weight, We can look at the average age of mothers, and there's also some data around things like average pre-pregnancy BMI, births by C-section, full-term births, births at home or induced. So there's a lot of different ways to look at where the mother is in her journey, as well as what the outcome is for the infant in terms of preterm birth, live births, average birth weight. So if you pull this all together and you benchmark for your community, you can really take a look at what maternal health is like across a lot of different factors. And I will also just show that this is more than just a table. We have lots of different ways to display this, and a lot of times the most impactful way is to show a map. And so I'm just going to really quickly show you that we can curate this data at pretty much any layer. So we have the birth rate. But we've also put, if I'm zoom in here real quick, we've also put the hospital locations on here. So, you know, we've got a cluster of counties that have a high birth rate, but that's about 50 miles. It's about a 50-mile radius. I can pull out my radius tool and make sure. But I don't even know if Helena Regional provides OBGYN care. So you can start to see where you put multivariables on a map. So you can put up to 10 different variables from that table I just showed you and kind of create a heat map where they all intersect, and then look at where your assets are in order to provide those services. And so this is where the combination of that data curation and the visualization is so powerful to understand your community, to plan meaningful interventions, and to advocate for some of the things that I think we're going to talk about with Dave and Will and Maria. You know, as they looked at their research, what are the things that they wanted to recommend that might help close some of these gaps? And so we typically on our webinars make these snapshots available. And so I'll put my calendar link in the chat. We have about 9 of these available. So if you want to set up one, I've got data from across the country. I'm more than happy to talk to you. Just set up some time on my calendar, and we'll go through and give you a data snapshot for your community so that you can have this data available for the work that you're doing. So I'll go ahead and do that as I tee up Maria and Dave and Will to talk about, you did this research, you took a deep dive. I always joke, I worked in policy for a really long time, and I think policy has a really big lever. It's a big lever to pull to have create equity across a lot of the things that we can talk about are derived from maybe not so great policy choices. So I'm really interested in what kind of programs, partnerships, policies you guys identified out of your research.
Do you want me to go, Dave?
Mhm.
Yeah, so I think that in general, we're looking more at the state level policies. And so in the health and wellness pillar, we have a Heartland Health Caucus that includes 6 states. So one of the things that we're looking at, for instance, is community health worker. And these are 6 states that are working collaboratively to look into legislation for community health worker. So when we say we want more community health worker to help women that are at risk or that they need to access resources and all of that. Okay, how do you take that? What is it needed at the state policy level for that to happen? And so for that, we need legislation that would define, that would pretty much create this workforce at the state level from a legislation perspective, right? The same thing for, we have nurse midwives, we have doulas, different types of midwives, not just nurses. And so all of these are needed in this new model that we are proposing that needs to be considered, right? And then when you think about, okay, we need more OBGYNs as well. So what do we need to do? We need to probably provide more scholarships for more, for the younger generation to go to med school and specialize in OBGYN, particularly people of color, right? So those are the things that we're looking at from a perspective of legislation, and also educating the public. Okay, what is actually, many people don't really know what a midwife is. Many people don't know what a doula is. We face many legislators who need to be educated sometimes on what is a doula, why is this important, what's the difference between a nurse midwife and another certified midwife, and why are both important, and all these things in terms of, again, when you're thinking about access, you need that workforce, and when you're thinking about workforce, you have to think about legislation. I can add a little bit more on that, just in the sense that there's a lot of initiatives happening across the states, local and statewide. There is practically no coordination. That is a critical thing because I don't know what it is, but at the local level, but also statewide level, we assume that the coordination is going to come from the sky and someone is going to do it and is going to do it for free. I encourage states to think about first mapping out what is out there already. What is your starting point today with everything that you have? Because you may be having already those boots on the ground that are champions on what they're doing, and you want them to continue that job or even to expand or to copy their models, right? And then after that, come up with the statewide strategy. Okay, how are we going to get it done with what we have already? What needs to be improved? What needs to be expanded? What are the policies that need to change? And then focus on having a strategy, not just, okay, let's introduce another maternal health bill next year. Because what happens is every year we have a lot of legislation that's being introduced. Some of them are passed, but there's no strategy behind that. And that is a problem over time because that creates more fragmentation and more confusion.
Yeah, I would just add too that one of the things that Heartland Forward has spent a lot of time working in is around broadband accessibility. And so focusing on helping states and local governments be ready for the BEAD funding that's starting to come down now. And so as we look at, again, this kind of portfolio of barriers to workforce, for example, how can technology and access to high-speed internet be a tool that we can use to facilitate whether it's participation in the workforce directly, education, or in this particular case, how can we, recognizing that not only do we currently have a shortage, but the projections suggest that we're going to be even more short of OBGYNs in the next 10 to 15 years because of retirements out of it and other disincentives that are currently in place around malpractice and things like that. And so, how can we create these partnerships between doulas and midwives and nurse practitioners in rural context that then provide telehealth to specialists in the more urban areas as one possibility that we suggest is worth exploring. I also want to touch on Brandon's question. So if I'm being completely transparent, the data that we had to use for our analysis was focused on the vitality statistics series that the CDC puts out. And so our understanding of the mothers was somewhat limited. The mother-focused data set, which is called PRAMS, is only available at the state level. And again, we lacked the ability to really break that down without either violating confidentiality issues or our margin of errors were just so big that we couldn't really say anything representative from the estimates that were generated. And so our workaround for that is we do talk about educational attainment as well as race, but we don't have specific information about income. And so you can make inferences about the socioeconomic status and why people are moving. And so one example of that is we do see a larger share of white women who also tend to be more highly educated, leaving their county to seek medical care. And so we suspect, but again, we can't, with the data that we have available to us, say that they are in a position where they have access to transportation. They may not have constraints in terms of their work environment. And so they have the ability to go and seek more expensive or specialty care or higher quality care, in a county or two over. But again, we can't, the data doesn't allow us to say that definitively, but.
I want to tag into that a little bit on the telehealth that Dave mentioned, and then also what he just said in terms of traveling. So telehealth can be extremely effective in two ways in maternal health. So one, access to specialists, but even and that can also be accessed even to OBGYNs if they're being attended, say, by a nurse midwife or another midwife in a county where they're far from an OBGYN. Telehealth through the clinic or with that provider that's actually enabling and helping with that patient access that specialist. So it's not from the traditional home where you sit with your computer and you access a specialist. That's not what I'm saying. So that means sometimes we need infrastructure in those rural clinics, or if you're having birthing centers, where you can access specialists through telehealth. The other component that was measured was also the problems with mental health that we have with throughout the perinatal process, the perinatal stages. And so having access to telehealth from the home for rural communities is extremely important. So if you take that to, okay, policies, at the federal level, we need ACP, basically. We need to expand access for particularly low-income women to be able to access the internet. When it comes to the state legislation, sometimes we need better legislation to expand access to telehealth as well, in terms of defining what telehealth is for the state, and also allowing for out-of-state providers, because that's how you extend your workforce that's already in shortages at the moment.
Yeah, you raise a really good point. We do have a couple of data sets around broadband access. That's been a really hot topic for a lot of reasons, not only COVID and work from home, but things like shortages and access to specialists and things like that. So I'm going to add that to our data snapshot, which, just by the way, we have 5 of those left. So Lisa, if you want to put that link in there, if anybody else wants a data snapshot of their community, I'm going to add that internet access to that, because I do think in the work we've done, we know that a lot of Medicaid patients have their phone. They can access things from their phone, but there's a couple challenges with that. Not everything is mobile friendly, and a lot of folks have limited packages on their phones. And so even though they could technically get access to the internet, they aren't able to use it for their healthcare or for some of these other important services, because, you know, they don't have the bandwidth is not the right term, but they don't have the capacity within their packages to be able to do that. So I think that's a really important point. And I don't know about you guys, but you've brought up a couple different areas where it seems to me there could be additional research. And if you guys have any questions from the attendees, go ahead and put those in the chat and we'll get those to our panelists. But one of the ones I wanted to touch on, and then I really want to hear about what other research you're thinking about, is you know, just that qualitative component. And I know you said you talked to providers, and Dave, you said you weren't, you know, you really didn't have that mother connection. So I'm really interested in, you know, what you heard from the providers that were working with some of these underserved populations, how you incorporated that into your research.
So we've incorporated in a couple of ways. One, in a very practical way, is we'll use quotes as part of our reporting. And so I should say the report associated with this work is still a work in progress. So we expect to be releasing that in the end of March, so in about a month. But in that report, you'll see these quotes throughout the report. So that's one way that we use it. But we also, through qualitative analysis, you know, look at the themes that kind of cross the interviewees. And so as we looked at both, again, with data limitations, you know, was there substantive comments and dominant themes that we could use to help infer where some of our data gaps were. But then the third way is it certainly informs as we look at how do we make the changes that are needed to truly empower women and to ensure that the care of women and our children, their perspective is critical, both because they're the ones that are going to be impacted most likely by changes to regulation or new licensing requirements, but also, they're the ones that because they're the ones impacted, they're also the ones that know firsthand where the bottlenecks are in the delivery of care, or how things can improve. And I would just reiterate that one of those critical elements is having access to preventive care, and being able to address especially chronic conditions early, i.e. in this case, before pregnancy, lessens a lot of the risks and a lot of the potential harm to the mother and the infant as a result of pregnancy. And so if we can figure out how to get mothers engaged in that process, but also free up doctors to be able to deliver that care, that would be huge.
And if I could touch on that, kind of we saw the same thing with postpartum depression. And a lot of what we heard was that if a mother went and just did more visits after she gave birth, and they could get mental health screened, and it could really take down the numbers of postpartum depression.
Yeah, and I would add to that. I mean, we focus a lot. Postpartum depression is just getting attention right now. Actually, there is attention to it, not as much as we probably need it. But on top of that, there are so many other mental health conditions that pregnant women or postpartum women go through that are not even touched on. And so having those screenings, but also how do you take that to the next level? Because a lot of providers are worried that now, okay, where do I send this woman after I screen them? It's a big issue right now. We don't have enough mental health providers. But what I do want to stress out, support groups came out as a big way to enhance access to mental health services. So sometimes like lactation services where women are connecting with other women that are also pregnant can be as effective as going to a therapist, particularly if that's not a very complex case of mental health, the problem or struggle that woman may be facing.
Yeah, and so as you guys, are wrapping up, I'm very excited to see the report coming out at the end of March. But as you're wrapping this up, what other kind of topics are you thinking about at Heartland Forward in terms of doing additional research? I know that you guys are always trying to look for those opportunities to really make a difference with the work that you're doing.
Yeah, so I'm going to limit my comments to just focusing on health and wellness, but we'll remind the audience that we do have ongoing work in entrepreneurship as well as in workforce development, and one of our projects around workforce development is really about growing healthcare workers. And so we've touched on it a couple of times throughout the webinar that's a key component of that access question, is do we have adequate access to healthcare? And so again, having adequate supply of workers is important. But in terms of where we go from here, in terms of our healthcare research, one area that we want to lean into is helping to connect the dots between health outcomes and their impact on state economies or local economies. And so that's not just simply, a traditional economic impact analysis, but really understanding how those conditions are impacting the available workforce and productivity losses, and really helping communities understand that if we don't have healthy workers, we don't have appropriate care for the size of our community and the types of risks we might face, that really becomes an economic development issue in the long run. And then the second area is that we're exploring ways that we can better identify health issues at the neighborhood level. So you might think of this as like a health index kind of idea, where we're combining a number of different outcomes as well as social determinants of health, for example, to identify where these very high incidence locations that could utilize more resources, and helping governments understand what the kind of impact they could have would be if they were to direct and dedicate resources to those focused areas, as opposed to just having them broadly available. And so that's another idea that we're kicking around. Again, it might take the form of an index, it might be more of a calculator tool that would be available on the internet, but something along those lines, again, really oriented towards state and local governments and helping them better allocate resources to addressing some of these chronic issues.
Yeah, I think that's particularly important as Metopio works across the social determinants of health and economic development, as well as healthcare and government. And there's so many different pockets of resources. And when you look at the challenges and the root causes, housing always comes up. And there's a lot of money that goes out the door for housing, but is it going out equitably? Is it going into the neighborhoods that need it? Once it's there, are people able to stay in their homes? It just unravels a whole bunch of questions. And I think that kind of boundary spanning work that really recognizes that if we help people be healthy, if we are treating these causes with seriousness and putting all our resources towards them, we actually are going to have healthier, more productive communities that can really live their fullest life. So that's really exciting.
Yeah, and to add to that, Angie, we would also cut on healthcare costs down the road
Right.
if we do it better, which is another economic benefit.
If you want to move politicians, that's really an effective lever for you to use. So I'm going to just launch our final poll, which is we love to do these kind of webinars, bring in experts, really interesting research that gives you maybe a little different perspective on how to use the data that we offer or that's out there publicly or that you have to really address some of these issues that we're all facing and that we're all really wanting to work on. So we've got a list there of potential webinars coming up. We run these every couple of weeks. I just want to express my thanks. I've had the opportunity to work with Heartland Forward. They're invested in a lot of different ways to build healthier, more prosperous communities and have a lot of smart folks there doing good work. So I really appreciate you giving our audience a sneak peek at what you're going to be releasing. And for everybody on the call, we'll be sharing our webinar as well as a couple resources. We've got a fact sheet that focuses on the research that Heartland Forward does. And if you want a snapshot, you can reach out and book that with me. I'm happy to share that for your community. I think it's really informative and can help the work that you do. So if you haven't let us know what you want to hear about next, we're more than happy to tee up some more webinars and keep you in the loop. We'll send out this recording and the information afterwards. Dave, Maria, Will, thank you for your time today. I'm so appreciative of you and the work that you do.
Thank you. Thank you so much, Angie.
Thanks, everyone. Thanks for being with us today. Take care.
Thank you.
Thank you. Bye.